Good morning, everyone. It's my pleasure to welcome you to our webinar, Insights from the Northern HIV Journey Mapping Project. My name is Ella, and I'm pleased to be welcoming our speakers today. The Northern HIV Journey Mapping Project took place from 2019 to 2025 and was a significant project for Manitoba. We're joined today for a presentation by Dr. Linda Larcombe, the principal investigator on this project, and Dr. Gayle Restall, the co-principal investigator on this project, who are going to take us on a journey through the research study results, recommendations for systems change. We'll then have a panel discussion with Dr. Albert McLeod, also a co-principal investigator, Melissa Morris, the project research associate, and Kim Templeton from the Manitoba HIV program, and also part of the project's working group. This webinar is taking place on June 25th, 2025, and we are recording the webinar today so that we can share it with people who are not able to attend. This webinar is organized by the Manitoba HIV-STBBI Collective Impact Network. This is a network of innovators working collaboratively to transform the landscape of HIV and STBBIs in Manitoba. We bring people together to tackle complex HIV and STBBI systems barriers, and we seek systems change by shifting the conditions that are holding the problems in place. If you would like to find out more about the Collective Impact Network, sign up to receive our newsletter, or find our social media and YouTube page, you can do so at cinetwork.ca. This webinar is part of our ongoing efforts to provide education, and you can find our past resources on our YouTube page. We will have a question and answer period after the presentation today, so I ask that you type your questions into the Q&A feature. You can type a question at any time into the Q&A feature, and we will address those at the end of the presentation. At this point, I'm going to hand it over to Laurie Ringaert, who will be moderating the panel today, to take it from there.
Thanks so much, Ella. And I just wanted to mention a couple of hats I'm wearing today. I was one of the co-investigators on this project, and really, really happy to be here with everyone. I'm also the co-strategic facilitator of the Manitoba HIV-STBBI Collective Impact Network with Linda and Mike Payne. And so today we're really excited to present the results from this research. And as Ella mentioned, we'll start off with presentation by Linda and Gayle, and then we'll have a panel discussion. And before we go over to Linda, I'm going to invite Albert to start us off with an opening in a good way.
Hello, Ella, do you have us on the main screen?
I can stop.
Sorry, what was that?
Yeah. So welcome everyone, and as customary here in doing community-based research, particularly on Indigenous areas, that we do involve elders and knowledge keepers to guide the process. And traditionally we do an opening invocation to call in the spirits to help us in our work, because we know as humans we have limitations. And so that's usually done through a drum song, a smudge ceremony, a sacred fire, or tobacco. So tobacco is sort of the offering to the spiritual world, the world of creation, to draw attention to us, and then to give our invocation to the spirits to guide us. So we open those doorways to the winds that bring change, the east, the south, the west, and north wind, that change our seasons. And now we are in summer, which is a time of plenty, a time of ceremony on the land, especially in the plains area. Lakota, Dakota Sundance, the Plains Ojibwe Sundance, and the Cree Sundance, which is about health and understanding spirituality and healing. The earth below, which again, as I said, will return the berries to us, the plant medicines, the waters, for our summertime as we get ready for the fall, and preparing our medicines and our foods. So the animals will return, and we know the bears have come out of their dens, and the different animals in the forest will provide us with the foods as well as the fishes. Then the world above is understanding that we are part of the universe, the mystery of the universe. As humans, we barely comprehend what the universe entails or cosmos entails, but a lot of that drives our spirituality in terms of our relationship with the sun and the moon and the stars, as well as the planets. And finally, us, the circle of humanity, those who choose to do this work around HIV and STBBIs, which can be challenging. That we receive the knowledge, the insight, the intuition, the epiphanies to do this work, and the courage and strength to do this work. So welcome everyone to our presentation today.
Thank you so much, Albert. I always appreciate your wisdom, and thank you for providing that today to us. I'm now going to hand it over to Linda, the PI on the project, and Linda will introduce herself.
Yeah.
Thank you.
Thanks, Albert, for that opening invocation. Words of wisdom for sure. So my name is Linda Larcombe. I'm a professor in internal medicine at the Faculty of Medicine at the University of Manitoba. And I shared the role as a principal investigator on this project with Dr. Gayle Restall and Dr. Albert McLeod. Let's see if we can. So I'd like to start with the land acknowledgement. The University of Manitoba campuses are located on the original lands of the Anishinaabe, the Innuak, and Anissinainawak, the Dakota, Iote, the Dene, and on the national homeland of the Red River Métis. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past, and we are dedicating ourselves and our research to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Whoops. So I just want to acknowledge that myself, Gayle, and Albert weren't alone on this project, that we had a very large research team working with us, including Dr. Orr from the University of Manitoba. Laurie is here today. We had peer research associates who were hired for working together with us on this project, Anne Favell and Melissa Morris. We had other research associate, Jared Starr, collaborators from Nine Circles Community Health Center, Mike Payne, other medical faculty at the university, and students as well. We're also working with beyond academia and Nine Circles. We had a working group from people, including people from Keewatin Tribal Council, the Northern Regional Health Authority, Kim Templeton, who's here today, representing the Manitoba HIV program. Also, John Kim from the National Reference Laboratory, Indigenous Services of Canada, and from the Northern Health Authority, Kim. So definitely community involved in a partnership research program. This is a bit of a complicated slide, but I just want to say that we started here up this stream a number of years ago, and we started upstream. We had a bit of a paddle in terms of knowledge about HIV in Manitoba. We had some resources available about previous research. We had some community knowledge about the rates of HIV and the implications for people living in the North. And as a result of research meetings with the communities in the North, it was from those meetings that it was specifically identified that we needed additional tools, additional knowledge to be able to address the rising rates of HIV in Manitoba. And specifically at those research meetings, we discussed the fact that there were a lack of knowledge about the barriers and the facilitators for people to be able to move through the HIV cascade of care, or the identification that an individual is living with HIV and what the treatment is, and to be able to live well with HIV. So we wanted to know from people who are living with HIV how the journey could be improved, and we wanted to create change so that people could live well with HIV wherever they choose to live throughout the provinces. So looking for culturally and geographically appropriate policies and practices and interventions for people who are living with HIV in Manitoba. And two of the ways that we were doing this was one through mapping the journey from a community perspective, mapping and additionally mapping the journey from the perspective of First Nations people who are living with HIV, and mapping the process of the journey from the perspective of the people who provided the health care to people who are living with HIV. And those are the goals that we had, the objectives that we had, and our approach was using a decolonizing approach, an Indigenous approach that recommends and identifies that we see the research through multiple lenses, through two-eyed seeing approach, and in an ethical space, which Dr. Albert McLeod took the lead on and helped us achieve those goals. So I'd like to turn it over now to Dr. Restall to address the next few slides.
Thanks very much. I'm very happy to be here. Good morning, everyone. I'm a Professor Emerita at the Department of Occupational Therapy at the University of Manitoba. Was very happy to be part of this particular project. So as Linda was saying, we knew from our partnerships, from the Collective Impact Network, the conversations that we had, that HIV is a critical challenge for First Nations people in Manitoba. And so this project we saw as very important to hearing about the factors that influence the HIV care trajectory for people, First Nations people, from across testing, linkage to care, retention in care and treatment, and viral suppression. And as Linda was saying, the major goal was for people to be living well with HIV and to be able to access the care and services that they needed. So based on the knowledge shared during this study, we recognized the need to create change in HIV care in Manitoba that directly responds to First Nations experiences. So we saw the knowledge of lived and living experience of HIV to be vitally important to this project. Next slide, please. So there were two parts to this study. The first aimed at understanding the HIV journey for First Nations people living with HIV in northern Manitoba, so we could develop recommendations for HIV care systems and really improve that care for people. And the second part was developing an HIV community readiness assessment tool. The goals of the tool are to strengthen community response to HIV by building on existing community strengths. So primarily, we're going to be talking about the journey mapping part of this project, but Linda will also talk about the community readiness assessment, and I believe the link to that community assessment, readiness assessment workbook is in your chat box now. So one of the approaches in doing this work was using a systems change framework. And this was important because we wanted to understand how to influence those complex systems that maintain the way things are and develop recommendations that would have the potential to create positive change for people accessing HIV care. And we recognized, of course, that those changes need to occur at multiple levels. They are very complex health and social care systems, and have been entrenched in colonial ways for a very long time. And we recognize that maybe looking at it from a systems change framework had the greatest potential of giving us the knowledge to where to influence those changes. The study was also grounded in two-eyed seeing and ethical space approaches. Led by Elder Albert McLeod, the team endeavored to engage with these approaches throughout this study. Next slide, please. So this slide illustrates the conceptualization of these two approaches within the study. With ethical space situated at the intersections, two-eyed seeing was about learning and enacting reconciliation. Two-eyed doing was about reciprocity and how there must be explicit and tangible benefits to communities. And two-eyed believing emphasized the relationships and valuing knowledge from lived and living experience. Next slide, please. So is there a slide missing?
Nope.
Okay. So maybe I'll talk a little bit more about the ethical space. There was another slide about the webinars that Dr. Albert McLeod had done related to webinars that he presented to the group on ethical space. We recognized that there was building capacity of the team was very important. And Albert McLeod developed a 4-part webinar series for the team. The themes covered in the series emphasized collective consciousness, demonstrative culture, aligning parallel paths, and modeling success. The other component of developing ethical space was really engaging community research associations as very integral parts of the research team. The role of the research assistants were where we engage people living with HIV. They were formal applications and interview processes hired by the University of Manitoba. And we did a number of training components so that the community research associates could really engage with the project. There were interview methods and procedures that we talked about in terms of trauma-informed research methods and ethical space. And the research associates were very important in participating in the qualitative data analysis and co-authorship for publications and presentations. And I'll turn it back over to Linda.
Thanks very much, Gayle. So I'll say at this point that as soon as we hired Anne and Melissa and we're ready to proceed with our training and doing interviews, COVID hit. So a lot of our plans and our aspirations had to be modified. So just keeping that in mind as we move through the methods and the research results, we're conducting this project all through COVID. So we used Zoom and or at the end of COVID in-person interview methods with 2 researchers, including one of our peer researchers. And we were using a tool that was a semi-structured qualitative questionnaire. And the participants were asked to describe their experience or their knowledge about the HIV journey using 6 milestones as guides. So the health journey before a positive HIV test and diagnosis, At the time of HIV testing and diagnosis, we asked questions about that period and that experience. When the individual was linked to care, what it was like to be retained in care, when there was the individual was prescribed antiretrovirals, and then living on antiretrovirals and living with HIV. And the interviews were transcribed and anonymized. And in terms of the analysis, the interviews were reviewed by the research team to develop an analysis framework. And then we worked with a MaxQDA software for data management and for some of the analysis pieces. We had a validation workshop to review the findings and to obtain feedback about those findings. And then we did some further analysis and synthesis. So in terms of the study participants, we had 18 people who are First Nations living with HIV, 13 were from Winnipeg, and 5 were rural and remote. They self-identified as men and women, and they self-identified as First Nations. And then among the healthcare providers, we had 5 from Winnipeg, 6 that were rural and remote. They self-identified as men, women, and non-binary participants, and they also self-identified as First Nations and non-First Nations. So just moving on to results, what were some of the barriers that were identified by the participants? There were 6 major overarching themes: lack of access to adequate health care, stigma and discrimination, lack of opportunities to increase HIV knowledge, social and environmental factors, geographic remoteness, and cultural safety. So I just want to read some of the words that the participants used to describe some of the barriers. One individual said that they were scared to go to the community-based HIV clinic because I thought people would see me and judge me. They'd look down on me and think less of me. And another participant said, well, back home, everybody knows everybody, and I have to be cautious about telling. Who do you trust? Who do you feel comfortable with? And a healthcare provider said, there's, dedicated, talented nurses at the nursing stations for the most part. But as far as the medical piece, they're sort of fly in, fly out physicians. And in my experience, there wasn't a huge amount of continuity of care. So just some of the overarching themes and quotes from the participants about the specific barriers as they move through the healthcare cascade. And we identified from those 6 sort of detailed themes some interrelated overarching themes that are intersecting. So HIV stigma was definitely an overarching theme, HIV knowledge and awareness, and confidentiality or the lack thereof in remote and rural settings. And each of those interrelated themes needs to be understood in the context of colonization and cultural genocide in Canada and Manitoba. And that means racism and its impact on people's ability to access healthcare services, including geographic remoteness, adequate housing, lack of resources allocated for healthcare services. So one of the things that we think about in going forward is how these interrelated themes might be addressed for future interventions and program for people living with HIV. And in terms of things that help people who are living with HIV, 3 primary themes are a collaborative and supportive healthcare relationship. And that came up over and over again, that key piece about having a relationship. Cultural and community connections, and a comprehensive care models and decentralized hubs for HIV care. So one person told us that I go to sweats. When I first found out, I was worried and I was thinking that people weren't going to like me and they're because of that. But I talked to the person running the sweats and I told them, and they were like, well, you're not going to get anybody sick. You're not going to pass it on to anybody because it's just a sweat, right? And another person said, I think there should be more parades, activism. Let people know it is okay. You should not have to live in the dark under a rock because these medicines, you can live a normal life. So definitely people talked about ways that help them live with HIV, and we can learn about the things that were supportive for people as they move through the HIV cascade of care. We identified recommendations for systems change, and these are going to be published and in more detail. The manuscript that talks about these systems change has been put out to publication. So we talked about recommendations for healthcare access and innovations, looking at the strengths of Indigenous leadership in healthcare and including Indigenous leadership in this realm, promoting relational, culturally safe, and trauma-informed practices based on community strengths, having community-led solutions, increasing public awareness to reduce stigma, and having measures that allow for and encourage and enhance accountability for people who are living with HIV who are in the healthcare system. With regards to the community's perspective on creating change for people living with HIV, we developed a workbook which specifically talks about how to create change based on community strengths. The workbook is a step-by-step instruction guide for conducting a community readiness assessment to understand where a community might be in terms of their understanding of the impact of HIV on their community and where they might need to have interventions or programs. The workbook includes 7 tools and worksheets and information that are critical for readiness assessment. And it was designed by an Indigenous-owned graphic design company, and we've had lots of positive comments about the design of the workbook. And it's a workbook designed as a starting place for communities who are looking to create change with regards to HIV and STBBIs in their communities. So while we were doing this project, of course, things don't remain static. So there's lots of changes being implemented in Manitoba since the study started. There's universal medication coverage for PrEP was initiated. The Manitoba HIV program has moved forward with a number of programs, including a Northern Hub, a PATHS program, which Kim will probably talk about, and changes to primary care. There's more HIV self-testing and point of care innovations in areas in Manitoba, and there's in the creation of First Nations health authorities. So all of these are opportunities for making change and opportunities and programs that are making changes for people who are living with HIV. In terms of moving forward, we want our research to move towards actions, and we have to be, I guess these are four different ways that we can move research to action. And one is to build on the strengths and to support community-led solutions. This is critically important to leverage traditional practices and community strengths and resources. We need innovations that support new technologies that enhance rural and remote HIV testing. We need to enhance collaborations and foster the two-eyed seeing partnerships among policymakers, researchers, and Indigenous communities, healthcare providers, and policymakers. And we need to emphasize preparedness. So using tools like the community readiness assessment to help reduce stigma in communities and in Manitoba by promoting HIV awareness and education. Part of our research, of course, has been sharing knowledge. The 2 red titles are community reports that are available on the SYN Network's webpage under resources. We have a couple of publications that are now published, and then 2 that are under review and will be available shortly, and then another publication that is in preparation. So knowledge sharing in sort of the professional realm, I would say, the community-based publishing, and also sharing knowledge at conferences and invited talks has been very instrumental in making sure that people understand what our research is about and what the recommendations are for moving to action. So just by way of concluding this part of our presentation, I want to thank the participants who shared their experiences with us. They were very generous with their experiences and knowledge. And I want to thank everyone who journeyed together with us on the Northern HIV Journey Mapping Project. So I will stop sharing my screen now and hand it back over to Laurie. Thank you.
Thank you so much, Linda and Gayle. Thank you for a fantastic presentation. That was really, really great. Before we go on to the panel, I just want to remind everyone, please, if you have any questions, please go ahead and put your questions into the Q&A area there on the bottom. And we will entertain any questions after the panel, just a reminder. So now I'm excited to introduce this great panel of people we have. And I'm wondering, Linda and Gayle, if you don't mind, stop sharing your screen, and we'll just focus in on our 3 panelists here. And so okay, we've got, I'm really happy to have the panel here. And we have Melissa Morris with us, Albert McLeod, and Kim Templeton. And I'm excited because they're going to bring different perspectives on some questions that I will be giving to them to respond to. And they've had the questions in advance, so they've had it's not that we're going to have surprise questions. So I thought, first of all, can we just go around and, if you don't mind, introducing yourselves? Melissa.
Yeah, hi, Tansy. I'm Melissa. Everyone calls me Mel. I'm Métis, a Two-Spirit person. Yeah, I was born here in Winnipeg. I started on this project, my journey, and so this was the start of my journey in research, and I think that that'll go to one of the questions. But currently, I work at the University of Manitoba at the Village Lab as the manager. I also work with 9 Circles in County Kanichak. So I'm really involved in the HIV community. I've been living with HIV for 17, 18 years now. And so yeah, I'm really active in the community. Yeah, thanks.
Thank you, Melissa. Let's go over to you, Kim.
Hi, everyone. I'm Kim Templeton. I'm the director of the Manitoba HIV program, which is housed out of 9 Circles Community Health Center in Winnipeg. Our program has a couple of different features in that we provide with partner sites care to people living with HIV in Manitoba, and then our small team here at 9 Circles Community Health Center works to support that care by way of education and training for healthcare providers. We do a lot of strategic planning in this space, as well as client navigation, supporting linkage and retention and care. Happy to be here. I'm also a member of the Collective Impact Network and was part of the working group team for the Northern Journey Mapping Project. Thanks for having me here.
Thank you, Kim. And of course, Albert, Dr. Elder Albert McLeod. I just so happy to be able to have this opportunity to always work with Albert on so many projects, and He and I've walked the land with Linda. Albert, do you want to introduce yourself? We've probably have some more people that have joined since you first introduced yourself earlier.
Yeah, I'm originally from Nepal, Manitoba, and my ancestry is Woodland Cree, Swampy Cree, and also Scottish, who worked in the Hudson Bay Fur trade in the north for many generations. And I live in Winnipeg now, as you can see with the background. But I was in Vancouver in 1980 when the beginning of the global HIV pandemic began. So my journey with HIV and AIDS has been 45 years, actually. And I returned home in 1983 and have been working in the Two-Spirit community, but also addressing HIV/AIDS issues, regionally, nationally, and internationally as well. I'm an advisor for communities, alliances, and networks for Indigenous STBBI responses to HIV, as well as the Peace Center for Indigenous STBBI research out of McMaster University. So my perspective is providing Indigenous worldviews and philosophies regarding, life philosophy, but also managing, bacteria that affect people as well as viruses. So this really fits into the experiences I've had over the last number of years. Welcome.
Thank you, Albert. As you can see, there's been a great group of people that have been involved, and Linda also talked about people on the working group. And I just want to acknowledge, I know I just kind of checked all the names of people that are on the webinar today, and thank you to many of you that have been on the working group with us. Thanks for joining today, and thank you for participating in this whole study. So let's go on with the questions. Are you guys ready?
You got it.
Okay, my first question, and Melissa, I'm going to ask you to start us off with this one. Which findings from the study stood out most to you personally or professionally, and why did it resonate? What did some of the findings resonate for you?
Well, and I actually really resonated with the quotes that Linda spoke of earlier of people, feeling the need to disclose their HIV status in ceremony, and not really having enough education around their rights as a person living with HIV, really circumstances around disclosure speaks to, and it also speaks to a lot of fear about disclosing in community, which really speaks to a need for education. We often hear that that when people are newly diagnosed, they don't know about the advanced medical treatment that's out there now. They think that it's a death sentence. They also have a huge, immense fear of stigma and discrimination, and those experiences also intersect with racism. It really compounds, and so a lot of the quotes that spoke to just disclosure, internalized stigma, perceived stigma, and even actual events of stigma really stood out for the need of widespread education about HIV.
Oh, thanks, Melissa. It sounds like from your perspective, it's still out there. It's the
Oh yeah, very much so.
Okay, thank you. Go over to you, Kim. What stood out for you most in this study? What did you kind of resonate with?
Yeah, I think my response is similar to Melissa's in that the interrelated barriers of knowledge and awareness and stigma and confidentiality just, I think, really reinforced to me that it's not a one size fits all, that we need to be working towards, and we really need to work towards choice, not only about facilitating options geographically for people to access care, but acknowledging that not everybody may want to receive care in their community and close to home. And we really traditionally have not been great at having a lot of choice for people in how they access care and where they access care. So that's certainly at the forefront of our planning as a program that does a lot of provincial work in this space. And I think, and I know, Albert, we've shared the sentiments because you've done a ton of traveling around the world and within Canada, is that when I travel to other jurisdictions in North America, there's HIV is in mainstream media. It's in very public spaces. It features all types of folks that are living with HIV, and that's not something that we do really well here. I'm thinking about the SCO's recent harm reduction campaign and how at the forefront that campaign was, and it was really distributed in lots of different spaces across the province. And I really hope that that we can do more of that in Manitoba to help normalize this and help reduce stigma.
Thank you, Kim. Albert, what really resonated for you out of the study?
Yeah, I think, it was just around people's fear of being, stigmatized about having HIV. And that's, again, because Manitoba doesn't have really public health campaigns about awareness, prevention, testing, and treatment for HIV. So a lot of people are uninformed. And that, in the early years of the pandemic, the federal government produced brochures that said HIV discrimination is illegal, right? Because people felt they had a right to discriminate and they didn't. It's like any other health issue. So again, I think in terms of the conferences we have in Manitoba and Winnipeg, women's health conferences, youth conferences, elders conferences, HIV it needs to be on the agenda because there's a lot of information people need to learn about, what is HIV, what is AIDS, what is the prevention available today, whether it's the male condom, the female condom, the PrEP drug that prevents HIV transmission, and then the different testing that is available, and then the treatment, and people living with HIV are the experts on their care because they know, what medications they're taking, they know where their immune system levels are at, and their viral load. So, people living with HIV can provide this support, and educate their leaders, whether they're First Nations, Métis, or Inuit leaders about this, and reduce that stigma, around, having a diagnosis, but also living. There's Manitobans who've been living with HIV for 35 years, right, because of the treatments, right? And so there's a lot of, especially for First Nations living in the North, there's a lot of leadership that is required to reduce the stigma and then to educate people about what HIV is. We haven't had campaigns for a very long time that really people lack the knowledge of what they're talking about. And that just sort of, promotes the stigma and fear.
Thank you. So a key takeaway, I would say, from all three of you is education and stigma.
Well, leadership, I think, too, like leadership.
Okay.
Like we have the Assembly of Manitoba Chiefs, the Manitoba Métis Federation, and then the Inuit Society of Manitoba. Like, that's why they're there. They're leaders. They're leaders in housing, leaders in education, and leaders in health. The time to step up to the plate and, profile, interest and advocacy around, ending the stigma, ending discrimination, and educating people about their human rights around HIV.
Thank you, Albert. And I'll just remind everybody that's listening to this webinar, either today or if you're listening at another time, what we're really hoping is that action comes out of the research. So if any of you are in that position to take action And these are, people are, making suggestions here. Think about that as well as what action could be taken. So
well, World AIDS Day is coming up December 1. That's also Indigenous AIDS Awareness Week, December 1 to December 7th. So there's a lot of opportunity in December for people to get ready. This is the time to get ready for a campaign or for a project, just around educating people and doing some leadership.
Thank you. Thank you, Albert. Okay, next question. And Kim, I'm going to start with you. Our next question is, in what ways has the project influenced your work, your life, your practice, or approach in this field?
Yeah, thanks. So recently, the HIV program has been trying to get really specific about what it means to be a care site that provides care to people living with HIV. And this is, part of our efforts to strategically partner with spaces, primary care clinics, Indigenous organizations, to facilitate better care for folks. And I, in trying to identify these factors and these elements, I think historically, obviously, clinical expertise and knowledge in HIV care has been at the absolute, forefront and necessary to provide care for people living with HIV. But I think now there's such a strong acknowledgement for the necessity for spaces to be Indigenous led, and for spaces to be able to have access to Indigenous cultural supports, as well as for spaces to be stigma-free, non-judgmental, and be trauma-informed. And I think there's just an acknowledgement that without these relational elements, that we won't be as successful in the care of people living with HIV. I think where there's a balance that needs to be struck is that not all communities are going to have clinical infrastructure to be able to support people living with HIV, but acknowledging that where spaces may need more education around stigma, around HIV, that acknowledging that the Manitoba HIV program should have a role in supporting those additional relational elements, having a role to connect spaces with Indigenous organizations, and being able to identify experts in stigma and trauma-informed care, and being able to support spaces that we partner with to work towards excellence in all of these spaces. So that's certainly something that is influencing how we move forward.
Wow, that sounds like a lot of good work there, Kim. Albert, I'm going to go to you next, and we're going to let Melissa close this one, but I'll go to Albert first.
I think it is really about realizing, that because of, stigma or alienation from birth family or community, a lot of people living with HIV have a chosen family or surrogate family. And that could start with their doctor, their social worker, other HIV positive people. But again, it's that connection to community, because a lot of our health services, they close at 5 o'clock. And they're not available on the weekends. So what are you doing? What are we providing for people in the evenings and the weekends? Because life goes on. And one of the things we should be doing in Manitoba is a camp for the children of HIV positive parents, whether they're single parents or couples who have HIV. Their children, we should be taking them out to camp or a picnic or something in the summertime. This is a wonderful time to be on the land. And we're just not aware of that need, right? About community, about family. Whether you're living in the north or living in the south, what is the community environment? How are you engaged in community? You know, so that's my objective is really about empathy, you know, for people who are diagnosed. And definitely this research tells us what people need and are asking for. It's up to us to respond, but from a holistic point of view, not just from a clinical point of view or social service point of view that says, I'm available between 9 and 5, and after that, I'm not available. That's not healthcare, right? That's health service, and that's clinical. So we need to go beyond the clinical and more look at the social needs, the cultural needs, the family needs.
Thank you, Albert. Okay, over to you, Melissa. How and what ways has the project influenced your work or life or practice or approach in this field?
Yeah, so I really feel fortunate that I came on. I think like many other people living with HIV, you know, we want to do more and want to get active, and this project really was an opportunity for me to learn in the field, learn from Albert, who just, you know, really inspires me to learn these things. So since the project, right, I've continued working in research. I was working at Gani Kanichik for 4 years. And we started looking at some of those social things outside of clinical care. We have monthly HIV sharing circles for people living with HIV where we come together and we've been drumming, you know, we gather over food, and we really connect on a kinship level, where yes, this is our chosen families and stuff. But I still, you know, when it comes to the academic portion of the research, I kind of, you know, found something that I really liked, right? So I've continued on with my work in research. I work with the Village Lab at the University of Manitoba. I work with Nine Circles in a research capacity, and I worked with Winiska on the Feast Center also. And so I really, it's really inspired my passion to learn. And so now I'm doing my undergraduate degree at the University of Manitoba, and I'm really carrying through, you know, learning from my elders, but also applying the stuff that I learn at school about colonialism and racism and how that still impacts and how it impacts, you know, people being diagnosed, Indigenous people being diagnosed with HIV, and you know, the way they access care and the racist policies and the lack of care. So it's really inspired me to do more.
Wow, Melissa, thank you for sharing that that journey. I mean, I'm so excited to hear that journey, and I know I've been around as you're going on that journey, and you just inspire me with what you're doing. Um, I just want to say I'm so excited about this panel. It's incredible the knowledge that we're hearing here, and so I'm really excited about what we're hearing. I want to remind everybody that we actually this webinar is longer than the normal ones. We have an hour and a half. So so we're not stopping at 11. I have a couple of more questions for our panelists, and then we're going to go on to the questions that you may have. But as you're thinking about what you're hearing, maybe you could also pop into the Q&A or into the chat what actions you are thinking you might take from hearing what we're hearing in the webinar today. So that's my challenge to everyone. Our third question is, have any of you observed any shifts or changes in policies, practices, or relationships in your systems or networks since the project began? So I'm going to ask perhaps Albert, have you seen anything shift since we started the project?
I think, through the collective impact network model, we brought a very, diverse communities together, like Dr. Barry LaValle from Kim up north, Dr. John Kim, who's a HIV researcher and promoting HIV testing. So we've had a lot of opportunity to access to different knowledges, right, that we probably wouldn't normally have. Whether it's the, clinical care for HIV or whether it's the new testing methodology that's available, like the self-test. And then we get to sort of learn about these mechanisms, whether they're federal, provincial, territorial, and how the health departments are dealing with the rollout of this, intervention. And I think like the PrEP is the pre-exposure prophylaxis is available in Manitoba. And in terms of the First Nations, just with ISK, First Nations Inuit Health Branch, the non-insured health benefits, which medications or treatments are covered in response to HIV for First Nations in Manitoba. So there's all these pieces. So I think it really is, it's a learning curve for everybody, and everybody has their own skill set. But I think it really does influence policy or legislation in terms of health delivery in this province, and it has done in Manitoba.
Thank you, Albert. Kim, have you seen any shifts happen?
Yeah, I think that maybe the most obvious one for the obvious shift for me in the last couple of years was just with the change in our provincial government, and just noticing that they have allocated more funding and resources to Indigenous organizations to provide both cultural and clinical supports to people living with HIV. But not only funding allocated to these organizations, but they've provided the Manitoba HIV program anyways with their infrastructure to, I'll just talk a little bit about this one project related to paths, that there is a desire to evaluate the quality of service of paths, or the cultural safety of paths for participants of the paths program. So this is an outreach program for people living with HIV. And we don't necessarily have the infrastructure to do that well here at the Manitoba HIV program. So Shared Health has allocated their own infrastructure to support us to do that work with Indigenous leadership. So we've partnered with Ongomazwin Institute for Health and Healing and the Center for Healthcare Innovation to develop a process again to evaluate the quality of service for participants of paths. And I think to me what that says is that leadership in this province is holding us accountable, the HIV program, to providing quality care and quality service to people, particularly Indigenous folks, who are receiving care through the PATHS program. So that is, it's encouraging for me. I think there's a long way still to go, but it's a breadcrumb.
Wow. Thanks, Kim. That's a big shift. Albert, you've got your hand up.
Yeah, and I think, Melissa mentioned that, the HIV positive support group is at Ringaert Sexual Wellness Lodge. And I think that's another example of a shift in terms of Ringaert Sexual Wellness Lodge has been funded by the province for like a community care outside of a clinical center. So it does have CUCUMs and aunties providing support, and they do harm reduction. And it's in a community environment where ceremony is accessible, elders are accessible, and so but also the HIV testing is also accessible through nurses. So it's that collaboration, that model that is outside of like a health center or a clinic, where people living with HIV, whether they're Indigenous or not, can access this particular type of care that is more community-centered and more culturally safer.
Good example, Albert. Go over to you, Melissa. What shifts have you seen?
Yes, so yeah, mine are similar to Albert's where and Kim, where we've seen a shift towards Indigenous led solutions or interventions. I wouldn't say a solution, but working towards taking care of some of those components where Indigenous people know how to take care of their people, and so we've definitely seen a shift with the NDP government now to really moving that forward. And yeah, so I'm just I mean, there still is so much more that needs to be done. There needs to be a lot more infrastructure. There needs to be a lot more investment. I mean, these are just little wins, right? And so what we need is more dedicated funding, long-term and sustainable funding for social programs, Indigenous-led social programs, and Indigenous-led clinical responses. Well, it's been a win to have Aboriginal health and wellness now supporting people living with HIV through clinical care, but still not accessible to all people that want to access care there. So I think there's still a lot of work that needs to be done, even though we've had some good wins. Yeah.
Well, Melissa, you took us right into the final question, in fact, about some recommendations to what are the recommendations to build on the momentum of this project, whether in research, service delivery, and collaboration. And you actually gave us some ideas there about service delivery. Is there anything else, Melissa, that that you would recommend? And this is a lot of people are going to hear this, so this is an opportunity, panelists, to say what you think your recommendations are. So go ahead, Melissa.
Yeah, so I think that really so just a lot more infrastructure. We're just really starting to build our response in Manitoba, and we're so far behind all the other provinces that we just need to start, right? Everybody needs to do those everyday acts of trying to make change, right? And so, yeah, really think about what can you do to move this forward, whether it be from talking about it in your own social circles, to actively attending activism, rallies and stuff, to supporting community-led Indigenous programming.
Thanks so much, Melissa. Kim, over to you. What are your recommendations to keep this moving forward?
Yeah, I think like broad sharing of this report for sure, and the outcomes and recommendations of this project. I intend to immediately start weaving the recommendations for change from this project into our funding requests, into our strategic plans, but also sharing it broadly with Indigenous leaders and policy and decision makers, as well as healthcare providers, particularly in urban settings that provide care for people living with HIV. I think there's a real disconnect between urban healthcare providers and people in northern, rural, and remote communities that are living with HIV, and many of whom were participants in this project. And I think what this report helps to do is bring those voices to the forefront and allow healthcare providers to acknowledge some of the challenges and hopefully force some evolution in access to care.
Thank you so much, Kim, and great action that you're actually gonna take through the HIV program. That's great. Albert, what's your
For me, part of my activism is, Some of my friends who had lived the first 20 years of the HIV pandemic, we identified 60 of our Two-Spirit friends. 48 had died of AIDS.
Mm.
And that's a huge loss to our community, to our history, And so I wrote a letter to the Minister of Health asking for Manitoba to create an AIDS memorial for Winnipeg. That was October. I haven't had a response back. But really that shows that level of denial of our leaders and our government to what happened over the last 45 years with HIV and AIDS and the pandemic. It is a global pandemic, It's happening in Africa, it's happening in Asia. And many of those people don't have access to antiretroviral drugs. So here, we're so tentative and we perpetuate that stigma ourselves. And, having an AIDS Memorial Winnipeg would really say we've been impacted too. We're not immune to these pandemics that go around the world. And it's up to us to show that empathy. And an AIDS Memorial for Winnipeg would do that.
Mm. Well said, Albert. And I respect Albert. Albert does go to a lot of international meetings. Has a really good handle on what's going on internationally for us as well. So thank you. Well, thank you, panelists. That it was such wisdom from all of you. Before we go into the questions from anyone, I just want to say we do, as I said, the idea of the research from all of us here is that we do want you to move to action in whatever realm you're in that are listening to this webinar. And do look at the links where you can find we've got the community report, and then the workbook, and then Linda did let you know about some of those publications that are already published or will be coming out as well. Please be in touch if you do want to know more about those. So now let's go on to the questions, and I'll just ask Ella if we've received any questions.
We have one comment in the Q&A so far, but everyone is welcome to submit questions into the Q&A feature at this time if they'd like. The comment in the question and answer is from Carly, who says, as a public health nurse, I 100% agree around the lack of media discussion on HIV. I feel like it's stigmatized because the residents of the province don't realize how common it is and that it's a manageable disease. Our province needs to work on our messaging and getting it out there.
Wow, well said, Carly. Anyone else want to put a question in here or just comments into the chat? What's your impression of the study? Anything that you think you might do next, or any questions you might have?
You're welcome to put those reflections into the Q&A feature, and you will also see in the chat a link to our survey. This is a really quick survey that just allows us to get some feedback on this webinar so that we can continue improving our webinars and use this data to continue receiving funding for education opportunities like this. So if you have a moment to fill that out, we appreciate it. And again, please feel free to put your questions in the chat, or sorry, in the Q&A feature. See some more coming in here. How do we do education and support in communities in which organized religion tries to block discussion of healthy sexuality?
I'm going to open this up to anyone. That could be Linda, Gayle, Kim, Melissa, or Albert. Albert, do you want to address that?
We used to say that in the old days, especially to elders who were resistant to sexual health information, is you have a choice with your grandchildren, you can either hold their hands when they're dying from AIDS, or you can educate them about sexual health and HIV prevention. That's your choice. You know, religion doesn't address HIV or STBBIs. You know, everybody has the right to sexual health protections from bacteria and viruses, regardless of religious belief.
Thanks, Albert. Does anyone else want to make a comment on that?
I would just say that I don't have a solution for it, but I would say that the community readiness assessment process, working through the workbook, could help a community identify what the issues are in the community, and perhaps maybe what some of the roadblocks are for interventions or education in the community, or what the strengths are. Religion doesn't necessarily have to be a roadblock, but if there's programs or ideologies in place, there might be some community strengths that allow the two to coexist. But definitely the workbook would help a community think through what the next steps might be, to provide opportunities for education and to be able to hold the hand of people who are living with HIV.
Thank you, Linda. Anyone else wanting to comment on the group, from the group? No? Maybe we'll go on to the next question there, Ella.
From an education perspective on health delivery, are there any workforce development or skills building needs?
Anybody move to answer that one?
I can chime in on that one. I think there's a lot. I think even from a training perspective for healthcare providers, occupational therapists, physiotherapists, nurses, doctors, that the amount of education that people are currently getting related to HIV is very, in my experience, quite minimal, if at all. And I think that that's a place that requires a lot of intervention right now, because I think that the healthcare providers have a couple of roles. One is to provide better care as a frontline worker, but also to be able to really talk in ways that dispel a lot of the myths about HIV, and to have a role in reducing stigma on a day-to-day basis. So I think there's lots of work that can be done in that regard.
Thank you, Gayle. Anyone else? Any comments on that one?
Yeah, I'll just reinforce that, yeah, there's an enormous workforce need for more education, not only to the public, but healthcare providers around this. Some of the things that the HIV program has developed over the last few years are clinical recommendations for prevention, HIV prevention, testing, and primary care recommendations for people living with HIV. And one of the things that we're working to do over the next year or so is to also develop HIV treatment and management recommendations for healthcare providers that are doing the ongoing monitoring of HIV for folks that they're caring for. And I think one of the challenges that we face as a program is understanding our role, particularly in the prevention and testing piece, because we are now so overwhelmed in the care of people living with HIV, and we acknowledge that public health certainly has a huge role, and as does primary care, in prevention and testing. And I think this is there's a lot of competing challenges here around workforce, and a very, I think we can all acknowledge, a very broken healthcare system in Manitoba right now, and with a lot of competing priorities, both environmental and health-wise. So it's not only having our own program infrastructure to now promote these recommendations. And I've completely lost my train of thought, but
Oh, thanks, Kim.
yes.
Okay, yes. Okay, thanks, Kim. I'm going to put a little plug in for the SIN network here, our Collective Impact Network. We have a partnership with Katie, and for the last few years, we've been putting on workshops, virtual workshops on HIV treatment, prevention. So there's more workshops coming up this fall. You'll get information through the newsletter. Make sure you're on the newsletter list and do spread that to other people, because these are some basic workshops. There's going to be one on PrEP this year as well. So those are always good for getting more information. Okay, let's move on to the next question, Ella.
Can you give more details about the need for decentralized services in your study?
I'll just mention and then let the others. That one was really about not having everything in Winnipeg, like moving. This is some of the work that Kim and the HIV program's been doing with moving into Thompson, etc. So I'll over to the panelists.
Yeah, and we heard from the participants that the requirement to be able to be mobile and come to Winnipeg for services was definitely a barrier for people to not only get tested but to be linked to care and to stay in care. And so that was a theme about decentralizing access to care directly from the participants.
And for some people, their support network is in the north, not in the south. So if you're sending people south to the city, you know, they have to rebuild their whole lives and support system. And when they have, you know, if you have, a married couple in the north who have HIV and have children, their whole support network is in the north, their families in the north. There's no need for them to relocate to Winnipeg. So whether it's Flin Flon, the Pod, Thompson, or Dauphin, that's where these resources, these doctors, these tests should be available so that they're not either flying or taking a bus. And you have to realize we don't have Greyhound bus service in Manitoba anymore. So people have to find a way to get south, and sometimes it's challenging. So that's what decentralized means. We need healthcare professionals, doctors in the north, who have an expertise in treating HIV.
Mm.
And we also heard that some of the tests that are done, the blood tests that are done on a regular basis, are the availability of them are limited because of the need to ship the blood to Winnipeg. So you might only be able to go for blood tests on Monday, Tuesday, Wednesday, Thursday, and not Friday, or there's constraints even when some of the services are available in the north, it's not the same as in Winnipeg. So lots of considerations.
Thank you. Anyone else want to comment on this one? No? Okay. Okay, I don't think we have any more questions, but to all of you here, panelists and Linda and Gayle, any final words that you want to say before we go?
I just wanted to reiterate my thanks to the participants who shared their knowledge willingly and with great courage, I would say, for the study and for our information and our knowledge. And we really appreciated their help with this study.
Yeah, and I think, as I said, we have World AIDS Day, December 1, and then we have the Indigenous HIV/AIDS Awareness Week following that. So there's a lot of opportunity to get ready for that. And CAN will be having a summit here in Winnipeg during that week, the first week of December.
Thanks, Albert. Anyone else? Final words? No, okay, thank you. My thanks to this great group of presenters, panelists. Thank you to all of you. Thank you, Ella, for hosting this webinar. And now I'm going to hand it over to Ella for final words. Thanks, everyone, for being here today.
Thanks everyone for joining us. Again, if you have a moment to fill out the survey, it is in the chat. And if you are part of our newsletter, we will be circulating information about upcoming webinars through our newsletter as well as our social media. If you are not, you can find that information at cinetwork.ca as well as resources on our YouTube page to our past recordings. So thank you everyone for joining. Have a great rest of your day.